The idea behind a gastric bypass is to reduce the amount of food that you can initially absorb by creating a smaller gastric pouch within your body. We call this the Roux-en-Y, Roux-en-Y bypass. What happens is that you have a gastrojejunal anastomosis and a jejunal anastomosis. The gastrojejunal anastomosis is when the stomach is anastomosed with your jejunum, and as you can guess, the jejunal anastomosis is when the jejunum is reattached to the jejunum. Let's just call this the JJ anastomosis. The JJ anastomosis is where pancreatic enzymes and bile acids come from the pancreas and go back into the common limb, whereas the gastrojejunal anastomosis is where your dietary nutrients or the food that you eat go straight to the jejunum. The whole point of this is to eventually have weight loss by reducing food intake and also promoting malabsorption. Now you can imagine that there's a lot of post-operative complications that can happen when you do have this. Because you made the gastrojejunal anastomosis, you have progressive narrowing that can occur, which is what we call stomal stenosis. This is usually because you just cut the nearby tissue, it causes tissue ischemia, and you can have ulceration that happens. The patient can come with nausea, they have postprandial vomiting, meaning after they eat, they start vomiting, they have GERD, dysphagia, and it can be so bad that they can't even drink liquids. The number one thing you should do if someone has a Roux-en-Y gastric bypass and they have difficulty tolerating foods in any way, you have to do an EGD. What we can do during the EGD is have a balloon dilation and it open the narrowing that is occurring. If the balloon dilation doesn't fail, then you can use surgical revision. So let's say that the patient does not present with these symptoms, but they do come with some abdominal pain, they have a little bit of diarrhea, and then you check their blood pressure and they're hypotensive, they're also tachycardic, they're also sweating a little bit, and they say that they feel lightheaded. Well, you should be thinking about dumping syndrome. What happens in dumping syndrome is when you have very high osmotically active material inside the gastric pouch. This can be simple carbohydrates. What it causes is an abrupt transfer of fluid from your circulatory system straight into the intestines. This fluid shift eventually causes some small bowel distension, causes vagal stimulation, and then you have increased intestinal motility. The management for this is to have smaller meals with complex carbohydrates or foods that are very rich in protein and fat, and after they eat, you want the patient to sit 30 to 60 minutes in supine position after they eat. Sometimes if they're being tachycardic, you can give them beta blockers. Now that was early dumping syndrome. So in early dumping syndrome, that's usually within the first 15 to 30 minutes after they have a meal. But what happens if they have GI discomfort, hunger, and lightheadedness hours after a meal? You want to start suspecting late dumping syndrome. This is where you have very quick absorption of glucose in the small intestine and it causes hyperglycemia, you have too much insulin, and then it causes hypoglycemia and a large release of catecholamines. What you want to do for management here is give dietary modifications. Second line treatment would be octreotide, and last treatment would be surgery.